Elbow pain can be very confusing and very complex, and there's a lot of things that we have to rule out when dealing with elbow pain. And a lot of times, especially if you get on Google or on any sort of search engine, you'll start to find things like carpal tunnel or medial epicondylitis, golfer's elbow, tennis elbow. One of the forgotten diagnoses and one of the more simple diagnoses and easier fixes is something called Pronator Teres syndrome. The Pronator Teres is a little muscle in the forearm that runs diagonally, and the job of that muscle is to turn the hand over into something called pronation, okay? So if you are a golfer, a baseball pitcher, if you are a mechanical worker like a carpenter or a mechanic who work a lot with screwdrivers or hammers, things like that, this could be a muscle that is very involved with you, and why it's important to rule it out is because we don't want to undergo all these more complex procedures for things like carpal tunnel if it's an easy fix with the Pronator Teres muscle with something as simple as like an active release technique. So today we're going to go over how we rule out those more complex conditions and how we treat this Pronator Teres syndrome once we kind of honed in on that being the cause of your symptoms. Pronator Teres syndrome is one of those conditions where it's not overly complex to treat, but the complex aspect of it is it can kind of hide behind a couple other pseudo-diagnoses in this case. So the couple things we have to rule out, the big one here is nerve tension because the median nerve, the nerve that's responsible for carpal tunnel, travels right kind of near the Pronator Teres. So if there's any inflammation in that Pronator Teres muscle, which lies like right here in the forearm, diagonal like that, it can cause the numbness and tingling in these three fingers that we often see with carpal tunnel. So patients will think they have a wrist problem, but really the nerve compression is coming from the elbow, not necessarily the wrist. So another thing we'll check here is also to make sure that nerve tension is not coming from the neck. So we'll go ahead and show you how we rule out a couple of those conditions. We'll start up close to the neck and we'll work our way down into the wrist. So the first thing we do for our patients when they present with any sort of radicular symptoms or numbness and tingling into those first three digits is what we call a neural tension test, okay? So we'll have the patient come out, and what we're doing is we're just trying to put tension on that nerve, okay? So if this reproduces, what we're doing, picture the median nerve like a piece of linguine, right? A piece of linguine pasta that runs through the arm, and as we stretch it like this, it puts tension on that nerve, right? So if that increases symptoms, we know that there's going to be some sort of median nerve compression going on in that area, okay? So once, we'll ask the patient, do you feel any increase in numbness and tingling here? If they say no, then we know that we're not really dealing with something in the elbow. We might have to go a little bit further north. So once we establish that this is normal, we'll have the patient turn their head to the left as far as they can. Any increase in pain into the fingers here, if they say no, we'll have them bend over here to get full tension on that nerve. So that nerve comes from the nerve roots in the cervical spine all the way down into these first three fingers. So you can see how that nerve, that piece of pasta, is completely stretched out with the maximum amount of tension possible on that nerve, okay? So that's one way that we rule out to make sure that we're not dealing with a cervical radiculopathy. And if that was the case, if they were to say, oh yes, actually I feel that go all the way down my arm, that cues us into that we need to start looking away from the elbow and the fingers and more into the cervical spine. So that's a whole nother video. For today's sake, we're gonna talk more about, okay, let's say that these tests are negative, and we're gonna hone in on Pronator Teres syndrome. Another thing we have to rule out, especially in baseball players, is something called the ulnar collateral ligament. You might know it as the UCL. It's the major ligament in the elbow that's responsible for Tommy John. And that lives right in that same area as the Pronator Teres. We see this a lot, Pronator Teres syndrome, in our ball players, especially our pitchers, if they're pitching at a high level. So one simple test we do to rule out UCL involvement is something called the milking maneuver. So we'll have them come into this fully external rotation position, and we'll just apply tension in this position here. And if they say they experience some discomfort on that medial aspect of the elbow, we know that there could potentially be some sort of UCL involvement. That could be a good indicator, especially in a pitcher, for an MRI or further imaging. So another test we'll do is just called the valgus stress test, right? So we just want to make sure that we're not experiencing too much pain through there or there. So again, pain in those conditions might lead us to think off of the pronator teres and more into the ligamentous structure of the elbow, the stability type structures. So another thing we look at when it comes to elbow conditions is the shoulder, and a lot of times deficiencies and deficits in the shoulder can lead to an excess amount of stress in the elbow. So what I like to look at, especially with pronator teres, and especially in my ball players, is internal rotation of the shoulder joint itself. And the way we do that is we have them lying right here on their back, and we're looking at the total arc of range of motion here. So you can see that Ermias comes a little bit greater than 90 degrees here, right? So that's not a big deal. We want to see 180 degrees of arc. So he should ideally be able to get his hand onto my elbow from this point. So let's see where he can go. So he's not terrible. He does have a little bit of a deficit in internal rotation, and you got to be careful because a lot of times what we'll see is we'll push the patient, their shoulder will come off the table. We want to make sure that's not happening, right? And we want to make sure we're getting that full internal rotation to that full internal rotation of the shoulder point there. So this is a good indicator of potential, like the potential cause of pronator teres syndrome would be a lack of internal rotation in the shoulder, because what happens is, especially like we said in ball players earlier, when you're at that fully pronated state, there needs to be some level of internal rotation coming from the shoulder joint itself. And if you're limited in that, that pronator teres is going to have to carry a little bit more of that motion than it's really capable of doing. So it's very important to make sure we rule out any sort of deficit in the shoulder when it comes to these types of pronator teres conditions. Let's say, just for argument's sake, that we found a deficit like we did here at Ermias. A simple treatment for that is just ART on that subscapularis, which is one of the big internal rotators of the shoulder. So what we do is we just distract the scapula out towards me here. We apply a little tension to the thumb, and then we just externally rotate up like this. So this is one of those hurt so good type stretches, right? The patients love it and hate it at the same time, right, Ermias? Yeah. Good. Good. So this is a big one to help release any potential deficits in internal rotation of the shoulder. And then for the next one, I'm going to have you sit up and face this way for me. Good. So lastly, we'll go into, I guess, the grand finale, and that's the treatment of the pronator teres muscle itself. Okay. So the way we kind of evaluate that is we have the patient in full extension of the elbow here, and we just have them pronate or turn their wrist over it with resistance here. And that muscle, you can see that muscle pop out. So go ahead and relax. I'm going to have you focus right here. And then just go ahead and good. So you can see that pronator teres pop out nicely right there. And a lot of times if I get it to pop out like that and I can palpate it, there will be a lot of tension and tenderness in that area. So this is a very good indicator of that condition. And often, sometimes even when we palpate that, it may reproduce pain down into these three fingers like we were talking about before. So what we're going to do is we're just going to do ART on that area, okay? So we're going to bring Ermias up into this, we call it the Salt Bay position, right? So he's going to start fully pronated. This muscle does cross the elbow, so we want to make sure we totally flex the elbow there. I'm going to apply tension to the muscle, and he's just going to go ahead and extend the elbow and supinate for me. Good. And he'll feel a lot of stretch and tension in that muscle. And I want you to pay attention, so go ahead. I want you to pay attention to the shoulder also while he's doing this, and you'll see why we also examine the shoulder in these conditions. You can see how involved the shoulder is in this motion of the elbow. So it's very important to not only examine the elbow with elbow conditions, but also to look closely at the shoulder as well. Good, very good. Great, and the last thing I'll do treatment-wise is a lot of times because the motion that this muscle is responsible for is pronation like this, we want to look at the joint complexes that are responsible for that too. So what I'll do is I'll look at the radial head, and if I feel any fixation in that radial head, I'll just give it a quick little chiropractic adjustment, just like that. Very simple. A lot of times there's no pop or click, just a little bit of force through that area. We'll go over a couple stretches and at-home stuff you could do, or exercise components that we add to the care plan as well in the other room. So the way we want to approach rehab when it comes to this pronator teres syndrome is we want to build some strength in that pronator teres muscle itself. And we also want to build a little bit more mobility in the internal rotation of the shoulder, because you can see how much, if you watch as I pronate in full extension here, how much my shoulder internal rotation is involved. So that's a deficit, remember, that's going to put excess stress on that pronator teres muscle. So we want to make this guy stronger and make this guy be able to handle its job a little bit, do its job a little bit better. So that's going to be our kind of way of thinking through this rehab process. Another thing, a symptom we have to keep in mind with pronator teres, not as common, but it does happen, is that nerve tension, that nerve compression that feeds those carpal tunnel-like symptoms into the hand. So another thing we can do is something called a nerve glide. So why don't we start there? This is something you can do at home if you feel some tension through the elbow and some numbness and tingling. So we have the patient start in this 90-degree position and close their fist. Good. Then we'll have them open their hand, extend their wrist, pivot the elbow down and around, just like that. So you should feel a pull through the elbow, and we'll just have them repeat that process. Good. Good. And that will cause some tension, release of tension through this area. Fantastic. Let's do one more of those. Good. Good. So that's to help make that nerve glide through that pronator teres muscle. Next thing we're going to do is we're going to work on building strength through that pronator teres muscle. So we'll have the patient grab our TheraBand structure here that's very good at working the forearm and the wrist. And we'll have him rest the back of his forearm right on his thigh. And he's just going to turn his wrist over, trying to keep the forearm on the thigh. And that's building strength in that pronator teres muscle. So we'll have him just repeat that a few times. Fantastic. And I'm making sure that he's not rolling his shoulder in to help accommodate that motion. And he's doing a great job at that. And that's really it for that exercise. Then what we're going to do is we're going to focus on building internal rotation of the shoulder. If you remember, like we talked about dozens of times already, is how important that internal rotation is to the shoulder. And we're going to teach a simple towel stretch. So I'm going to have Ermias turn around. He's going to grab this towel behind his back. The side that's involved is going to be the lower side. So if it's the right side that we're working on, his right hand will be on the bottom here. Some people might not be able to get here. They might only be able to get here. That's okay. That's why we're using a towel. With this other hand, we're going to reach back, and he's just going to pull up with this hand to bring this back into deeper internal rotation of that shoulder, okay? So just I always say with any type of stretch or mobility work, you want to be flirting with the edge of your comfort zone. So we're going to coach the patient to pull up, kind of find that edge of your comfort zone and hang out there for about 30 to 45 seconds, okay? So that's how we coach this exercise. Lastly, we'll show you another stretch and mobility type workout or stretch you could do at home to work on the internal rotation of your shoulder. We're going to show that to you in the other room. The last thing we're going to do to work the shoulder mobility aspect of these pronator teres type presentations is we're going to do something called the sleeper stretch. This is probably the best and easiest at-home mobility type stretch you can do for internal rotation of the shoulder. We have the patient lay on their side. A lot of times I do recommend laying on the floor and pushing your back up against the wall just so you can maintain those proper angles. Go ahead and bend your knees for me. And then we're going to have you put your feet up against this imaginary wall here as well. And then just make sure that shoulder is back and it's not leaned forward like this. You want to make sure you're sucking that shoulder back up against the wall. The next thing we want to look at is at the elbow straight out in front of you. And then we're just going to have the patient let their wrist fall down towards the ground here and then apply little bit of pressure here, just like that. And that's stretching all of this posterior capsule of the shoulder. It's hitting the internal rotators, or external rotators, I'm sorry, of the shoulder, and it's gonna help that get into further internal rotation. Another thing we like to point out here is patients like to jam their hand down into this position. You will hurt yourself if you do that. I tell the patient to apply pressure to this area, and the cue I like to use is just slightly more than gravity. So he's not really pushing this down. He's just letting his hand rest there, and then maybe just a little bit more pressure. You'll feel that. And keep in mind that that same cue we used in the earlier stretch, just flirt with the edge of your comfort zone. So find the edge of your comfort zone. Make sure you're not, blowing past that, and make sure that you're hanging out at the edge of that comfort zone for a good 30 to 45 seconds. And also another thing to remember is always stretch bilaterally. So we always do everything that we spoke about today, especially with shoulder mobility, on both sides of the body. So that's really it for shoulder mobility, and thanks for watching. If you believe that you suffer from any of the conditions that we went over today, feel free to give us a call or reach out to us, and we'd be happy to take a look at you here at Health Fit Chiropractic in Boca.